Fall marks the beginning of the flu season in the United States, and for the first time, the U.S. will have to deal with a flu season that's wrapped up in a global pandemic. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, senior writer for AHA. In this podcast, Adam Myers, Chief of Population Health at the Cleveland Clinic and Director of Cleveland Clinic Community Care, talks with Nancy Foster, AHA's Vice President for Quality and Patient Safety, about what the clinic is doing for patients and how it's preparing for an increase of patients due to the flu.
Hello. I am Nancy Foster, the Vice President of Quality and Patient Safety at the American Hospital Association. With me today is Dr. Adam Myers, Chief of Population Health at the Cleveland Clinic and Director of Cleveland Clinic Community Care. Welcome, Adam. Good to have you here.
Thanks so much, Nancy.
As you know, we are in mid-October at the start of the flu season, and simultaneously we are seeing COVID-19 still very present in most communities across the country and on the rise in several parts of the country. What is the clinic doing to care for patients while preparing for a likely increase in the admissions of patients with the flu?
Yeah, this is going to be likely a tough flu season, secondary to the combination with COVID that is still rampaging across the United States right now. I'll say as the COVID-19 pandemic continues, it's even more important to receive the flu vaccination. That's one of our primary messages. We are strongly encouraging flu vaccination and offering appointment-only community flu vaccination clinics across Northeast Ohio. In addition, patients can also receive the flu vaccine at most scheduled in-person visits with a physician, nurse practitioner, or physician assistant. But as flu and COVID-19 have similar symptoms, it is not particularly possible just based on symptoms to tell the difference between them. Therefore, as the flu season approaches, in order to efficiently determine which diagnosis we are dealing with, we'll be simultaneously testing each patient for flu, COVID-19, and RSV using a test that we ourselves have developed here. That will help really direct the care toward the specific pathophysiology in play so that we can be most effective in doing so and take the appropriate precautions afterwards. Regardless, though, it's going to be a confusing time as every sniffle will be considered likely the worst case, and working through that delicately with patients and families and with each other in order to ensure that we have good outcomes is critical.
That's great. It sounds like you're taking a lot of steps both in prevention as well as improving the ability to diagnose whatever disease the patient is coming with. So, Adam, in the COVID era, we know that many patients with chronic conditions have not sought the care they might need during the pandemic. I know the Cleveland Clinic cares for many patients with conditions such as diabetes, hypertension, and heart disease. What have you done to ensure patients continue to receive the care they need during the pandemic?
Well, going into this, we knew that some in-person care would remain necessary. There was an early attempt to try to transition as much care as is possible and was advisable to virtual access, secondary to the need to minimize exposure for all involved. However, we knew again that some in-person care would remain necessary, and maximizing the safety of that care for both patients, families, and our caregivers was and remains one of our highest priorities. To that end, we worked hard to make it to where people could safely receive care within our facilities, involving robust screening of patients and visitors. We request that patients and visitors sanitize their hands frequently inside our facilities, that masks are worn, that outpatient encounters involve masks as well. We also have done some interesting things to try to promote distancing in waiting rooms in our settings. by using pagers and or texts to eliminate waiting room time so that the patient would come to one of our ambulatory facilities or clinic settings, let us know they are there via a phone call, and then we would text them when their room is immediately available, and then they walk straight in, go back, get roomed, and that diminishes the likelihood of people congregating in common areas. We've also continued extensive cleaning of elevators, door handles, common areas, and all of those different kinds of things that we've described. But however, even with these precautions, many have chosen to defer care, both elective and necessary care. Some of that has been advisable, obviously on the elective side, and things that we ourselves encouraged that just waiting down the line to do as advisable. However, necessary care has been deferred. And in order to try to combat that, we've tried to message the safety precautions that we put in place. However, if you think about it, as you stated, patients with diabetes and hypertension are at high risk for complications of COVID. To that end, ensuring tight management of those underlying comorbidities is crucial if we're to keep these patients safely at home. Pre-COVID, we had a chronic disease management remote monitoring program using connected devices, connected glucometers, scales, pulse oximetry, sphygmomanometers, and other devices to help provide us continuous and ongoing data on patients with these underlying conditions. And that program also included frequent outreach to improve those outcomes, and it proved very effective with many more of those patients who were enrolled achieving rapid control of their diseases than was the historical norm without the program. During COVID, we grew this program from about 2,000 patients to 20,000 patients in a mere matter of weeks. And for those who enrolled and remained active throughout this process, we have seen a 35% reduction in unnecessary inpatient care compared to a risk-matched cohort. So those are some of the things that we've done to ensure that ongoing care continues, that people feel safe when they need care within our walls, and importantly, that we bring as much care to their homes as is possible to ensure that safety.
So, Adam, that's incredible that you're using so much information to help people during this COVID era. Let's stick with those patients with the chronic diseases for a moment, particularly those that have an increased risk of severe illness from COVID. As part of your population health approach in general, you've been using data and expanded care teams to identify and engage those who need care. So how are you doing this even through this pandemic era?
Actionable data is absolutely critical for population health. To that end, pre-COVID, we had built our own risk algorithm, which includes 125 different variables, patient entered data, electronic medical record data, claims data, laboratory data, all combine into a risk score that each and every one of our patients that we take care of has. That score is clearly visible within the electronic medical record. And as that risk reaches certain thresholds or begins to rise for whatever reason, there's a colorimetric change, and that is highlighted for us so that we can then pay attention to a person's rising risk and even furthermore, understand which levers are contributing to that rising risk so that we can target our interventions. This is a critical effort because we can't do all things for every patient, and focusing our efforts on those patients who need it the most, and more importantly, also specifically targeting certain interventions for them is critical. And this registry has been fruitful in doing that. Early on, it became clear that this risk stratification tool would help us in COVID to determine which patients needed to be targeted for the expansion of our chronic disease management program. So we identified the top 20,000 patients within our risk stratification and then sought to scale the teams rapidly to get there. We had teams in place, but had to rapidly scale in order to meet the need of these 20,000 versus the pre-existing 2,000 patients. Simultaneously, many teams that were traditionally focused on more elective care found themselves with less to do as less elective care was being performed. We purposefully and proactively trained and redeployed those teams in support of our chronic disease management and our COVID monitoring programs and have found to be very, very fruitful.
Adam, as you know, COVID has changed the way hospitals provide care. Before the pandemic, we know many were really focused on moving from volume to value-based care delivery models. How has COVID made this even more important now? And what is the clinic doing to redesign care in support of the value transformation during this COVID era?
Yes, value is all about providing the best outcomes with the best experience and doing so with the greatest efficiency from an expenditure standpoint. I can't imagine how that would be any less important during this time. In fact, it has become much more important as the needs have risen and the resources that can be brought to bear as a nation have actually diminished because of a variety of reasons from an economic standpoint. COVID has again underscored the need for change in how healthcare is reimbursed. Many health systems still live in a volume-based fee-for-service model. To the extent that this was true, those health systems have found themselves without the procedural and non-procedural volume necessary to support their existing infrastructure, all while simultaneously incurring greater supply and overtime expenses. Prior to COVID, we at the Cleveland Clinic had begun a journey in changing how we are paid. 2.5 years ago, none of our primary care reimbursement came from upfront guaranteed payments, otherwise known as capitated payments. We were all fee for service across the organization. Now, we had some significant value-based arrangements, but at their core, they were still fee for service. In that model, volume of visits is what keeps the lights on. This approach, we felt, was counter to the proactive team-based population health management model that we wanted to propagate. To that end, we began to change how we're paid. The reason for doing that was to free up our teams and allow for creativity for our teams to get off that fee-for-service treadmill and redesign care to what, where, and how it was needed and desired, not dependent on whether or not the care was directly compensable in the traditional sense. So to that end, we have now transitioned to where about 40% of our primary care payments by the year end will be in a capitated model. By the end of next year, we'll be approaching about 80% of our revenue coming from capitated model. We incorporated what we call panel management time previously in all of our ambulatory practices. This is where the teams would stop and pause and determine who in our panels needs our attention, not just who's knocking on the door and requesting appointments. These types of proactive approaches to population health management are amazingly impactful for the panels of patients who trust us with their lives. Now, in a fee-for-service model, during that time, no patients are being seen, none. It's the team stopping and thinking proactively about those that they care for, and then, as a result, reaching out. In a fee-for-service model, you would think that that's very unproductive. We've always felt like it was very productive. And now in this new model of compensation, it remains both a desirable thing. We're being paid for that time up front. But again, we did this to redesign care. However, during COVID, it's actually proven quite nice in that while other people across the nation and across our organization saw their revenue decline, within the primary care space, to the extent that we were in this guaranteed payment model, we've seen our revenue preserved, which has, again, allowed us to resource some of these other interventions.
Thanks. You know, Adam, telemedicine is not new, but it has been applied differently in the COVID era. Could you talk a little bit about how you're using telemedicine to care for patients these days?
Absolutely. Virtual care has always been a big focus, even prior to the pandemic at the Cleveland Clinic, but it became enormous. Prior to the clinic, up to the pandemic, we averaged about 5,000 virtual visits a month in January and February. In April, we set a record of 200,000 virtual visits. It became quickly almost 80% of our ambulatory volume. Now it's hovering down in the 30 to 40% range, but we hope it will never go away. We're using virtual platforms to continue our popular shared medical appointments, which grew significantly during this time. So groups of patients with a similar disease process all logging on at the same time, 10 to 15 at a time, having a shared medical appointment. And that has grown in tremendous popularity during COVID as well. And so since our launch in June of this approach, we've conducted over 2,000 shared virtual visits with those different groups of patients. I previously mentioned the chronic disease management program, which is in-home care that is digitally enhanced. I mentioned our home monitoring program as well. And we've also supplemented with basic traditional phone calls because not everyone has access to broadband. The digital divide, so to speak, has really made even more stark the reality of health disparities. And so traditional phone calls became a very important part of what we did in the virtual space. And true clinical decision making can occur in that fashion. And one final piece is that some areas such as behavioral medicine are now predominantly virtual. It works very well. And many say we may never return to the normal face-to-face in-person care for that population.
Wouldn't that be a switch? You mentioned this just a moment ago, but can we focus on an issue that has challenged the healthcare system for a long time, and that is health disparities? We know that COVID has affected communities of color across the nation, and they have experienced higher rates of infections and deaths than other groups. Recently, the city of Cleveland declared racism a public health crisis, and the Cleveland Clinic was one of many organizations supporting that resolution. Could you speak a little bit as to why the clinic supported the resolution and what you're hoping will come from it?
A great question. We support the resolution and the statements because it's true and it's the right thing to do. The structure of our society has placed Black Americans and people of color at disadvantages for hundreds of years. Those political, economic, educational, transportation, judicial, social, housing, food, and health access disparities have increased disease states and decreased longevity. Changing those outcomes requires changing the underlying realities, and we're committed to partnering with others broadly across our communities to doing that. It's part of our mission. Our community is a priority. There's no place for racism in this world from our perspective, and it is, we felt, our moral imperative to enter into this space and into the conversation, and even more importantly, into providing solutions in our local markets.
Would you say a bit more about how the clinic is tackling the health disparities, what specific actions you're taking, and how this might have been affected by COVID?
Yeah, the National Academy of Medicine and the public health literature are very clear now that traditional healthcare really only accounts for about 20% of a person's health outcomes. The other 80% is what is referred to as the social determinants of health. Things like safe housing, transportation, employment, access to healthy food, literacy, education. Let me just give you an example of what I mean by a social determinant of health. Let's take lead poisoning, for example, in children. While this is a tragic health outcome, at its core, it is a social fabric of society issue. It's a housing issue. It represents an issue where in many blighted communities, lead paint is a clear reality that has yet to be mitigated. So what we have is a social determinant with very clearly directed outcomes clinically. But simply chelating the lead and treating the disease is not the solution. Really, you move upstream to impact the social underlying cause of this in order to really fight the issue. And so that's what this is about. That's why tackling the social determinants of health is important, because we're not satisfied with only impacting 20% of the health outcomes. So to that end, a little over a year ago, we developed a comprehensive outcomes-driven community health strategy based on partnership. And the areas that we branched it into were heal, hire, and invest. Heal involves providing access, partnering with others in the communities who are providing access as well in partnership and support of them. And that involves a lot of different approaches, but in order to strengthen our communities, hiring local as an anchor institution is critical to strengthen our communities. And so we've specifically developed programs to create job readiness, literacy, and job preparedness within some of our most blighted communities. And then investing local is the third arm of this strategy. And to that end, we're attracting small businesses to the community. Specifically, we're just announcing a grocery store in the community immediately adjacent to our main campus in the Fairfax community, which was prior to this a food swamp. There was food available, but it just wasn't good food. So it wasn't a food desert. It was what we call a food swamp. Additionally, we're investing millions of dollars soon, and we'll be announcing that in affordable and mixed-use housing and mixed-use business development in that same community, all in partnership with others. And the key element of this is partnership. We cannot do it alone, but we alone can do our part. We're collaborating and augmenting the federally qualified health center efforts in a lot of these communities. They were already there doing tremendous work. Why subvert it? Why compete with it? Rather, we're augmenting them with testing, with PPE, with support for virtual care. We've collaborated with other health systems on testing and other aspects of the interventions. Additionally, we reached out to faith-based organizations who are oftentimes some of the most trusted members of the community on how they can spread the word on COVID and intervene. So to that end, we've had several faith-based organization summits that myself and my team have organized, and we've reached over 1,000 congregations across 12 states, advising them on safe worship, self-care, care for others, and gave them a reopening sacred spaces workbook that we created for them, a real step-by-step plan about how to do so. And as the holidays approach, we're planning an upcoming summit as well on how to uphold some of the traditions associated with the upcoming holidays, but to do so safely. And a couple of other things, we've expanded our school-based health and flipped a lot of that to virtual in order to address the digital divide. We partnered with a local broadband company to place broadband boosters on the roofs of some of our buildings around our campuses to blast broadband access into those communities that had no broadband access so that they can maintain school access and maintain access to healthcare. We've supported and conducted focused community testing and have seen some of the disparate impact of COVID on those communities as a result to diminish. And these disparities, however, arose over many, many years. And I will add that it will take many years to create true health equity. However, we're committed in partnership to doing so.
I'm really inspired. Adam, would you say just a little bit more about how the pandemic has changed your population health efforts and what challenges the pandemic has created in trying to conduct those population health efforts?
Yeah, great question. What it's really done is, I think, pushed more and more care into the spaces where people live, work, play, and worship. To that end, we implemented pre-COVID a skilled nursing facility at home program, which actually became expanded and developed broadly. It's, discharging people home is a good thing. It's a safe space. It helps with length of stay. But during COVID, when we didn't want to discharge people to congregant facilities, it became even more important. So we've expanded that program and found that we can safely do so. In the early next year, we intend on implementing and developing a true hospital at home program, where for certain types of DRGs, we can either shorten the length of stay or do the entirety of a hospitalization in people's homes with full support from supply chain, nursing, pharmacy, et cetera. The chronic disease management program, which we previously discussed, was important for this. But what it also did was this has underscored the need for team-based care, the transition to value, attention to racism, and the importance of our health equity efforts, which are all key components of population health.
Lastly, as patients return to hospitals for more routine care, the non-COVID care, How are you communicating with your patients and communities to let them know that your facilities are not only open and ready to care, but are also safe for them, and you will do everything to limit their exposure to COVID while they're receiving care?
Ensuring the safety of those that we serve is critical, and messaging that we are doing so is equally important. To that end, we've done public service announcements. We've partnered with others to that end as well. We message that on our hold messages. We have posters and information that we send out. We message those people broadly who are on our mailing lists and on our email distribution lists and our text lists about how to safely access our care. In addition to that, we have had multiple layers of precautions, talking about screening patients, requesting patients and visitors sanitize, mask wearing, testing of all inpatients, encouraging emergency department patients to wear masks as well as reminders for social and physical distancing. We've removed some of the furniture from our lobbies and waiting areas to enhance that distancing. We've extended our cleaning services, and we're telling all about this. But all the while we work to do this, it's important that we also work to reduce the emotional distancing, which is a common result of social distancing. To that end, we have implemented the ability to use iPads and other forms of video connections between our inpatients and their family support systems so that they can remain connected with each other during these critical times.
Dr. Adam Myers, thank you so much for sharing your insights and experiences. I really appreciate the way you spoke about the purposeful and holistic approach that the Cleveland Clinic is taking to caring for all of the needs of the populations it serves, um, ranging from prevention to really thinking about the social impacts of care to really caring for those who are critically ill, and in need of the high level of skill and capacity that is available at the Cleveland Clinic. Thank you so much for your efforts. Please stay safe.
Thank you, Nancy. Always a pleasure to talk with you.
And you.